So it's past 4. Let's start with sepsis.
Yeah.
All right. So, as the title says, sepsis. So I came across this when I was with Roche, and I was quite fascinated by the concept of the PCT. And now that I work with a gynec hospital, mostly gynec, we have had cases of sepsis. Not many, but protein, starting off with proteinuria and high blood pressure and stuff like that. And of course, those cases afterwards they were shifted to uh, the bigger hospitals because at Mowdawala we don't have that much of a facility. But now we do have an ICU, and recently we haven't got any cases because we have a PICU and we have a regular an ICU that can cater to adults also. So the question which I always start with, come on, first slide, sepsis. So sepsis is defined as a systemic inflammatory reaction to infection, response to infection. During sepsis, circulating phagocytes are activated and multiple mediators are released into the blood. The balance between pro-inflammatory and anti-inflammatory responses affects the outcome of sepsis in a patient. In predicting the outcome, the markers of systemic inflammation may help to identify patients at risk of severe sepsis or septic shock at an early stage of the disease. The clinical definition of systemic inflammatory response, SIRS, as we call it, is broad and may be present in many conditions other than infection, such as acute pancreatitis, trauma, burn injuries, and autoimmune diseases. And you can see some pictures below. See the hand in particular. Okay, you go to slide 3. The cause, the clinical events in the evolution of a complicated course of sepsis and concurrent steps in activation of innate immune system. Microbial structures activate mononuclear phagocytes by binding the CD14 receptors. A signal is transmitted into cells via toll-like receptors and results in the activation of nuclear factor kappa B, transcription of pro and anti-inflammatory genes, and the release of cytokines into the circulatory system. So your immunology is compromised. So here we have, if you can take a look, so you've got gram-negative bacilli, you've got lipopolysaccharide, endotoxin, all the horrible things coming through, and you've got your gram-positive cocci, you've got CD14 receptor, you've got toll-like receptors, and you've got the TNF alpha with the activating platelet activation factor and direct tissue injury, as you can see it. You've got the lungs and you've got the liver below and you've got the kidney. And you can see the plasminogen activator. You can see the clot formation into the vessels. Right. Somebody's coming in. Who is it? Just a moment. Parul. Parul, we've already started, just started, I think slide 3. Okay, then we come to the cause. Circulating neutrophils and monocytes become activated and express increased surface density of CD11B, CD18 molecules. Procalcitonin levels start to increase, and this is important. Genetic factors determine the magnitude of pro-inflammatory response and that the patient may develop shock. Deep immune suppression further complicates the course of sepsis. The chronological schedule should be considered as a rough estimate. So here we go. You can take a look at what is happening. You can see that the neutrophil is involved. You have the monocyte also. You've got TNF and IL-1. And then you can see all the other factors involved on the right hand side. Platelet activating factor, prostaglandins, oxygen and nitrogen radicals, proteases and bradykinin. You can see that eventually it leads to a sort of hemorrhage. Okay. Soluble markers, tumor necrosis factor TNFA and interleukin IL-1 are associated with the early pathophysiological events of septic shock. Multiple cytokines, including TNFA and IL-1, can be assayed by automatic analyzers. Although TNF-FA and IL-1 are important mediators in the pathophysiology of sepsis, they have only a limited value when used as markers of systemic inflammation in the clinical practice. So you've got PCT, fast and highly specific, increases in bacterial infection and sepsis. One major advantage of PCT compared to other parameters is its early and highly specific increase in response to bacterial infections and sepsis. Thus, in septic conditions, increased PCT levels can be observed 3 to 6 hours after the infectious challenge. Low PCT, less than 0.25 Ug, in patients with clinical signs of infection, like CAP and UTI, indicate a low probability of blood culture proof of bacterial infection, whereas elevated PCT values above 0.25, keep in mind that's your cutoff, seems to correlate with the bacterial load and positive blood culture results. So all these tests are done simultaneously. PCT levels in sepsis are generally greater than 1 to 2 Ug and often reach values between 10 and 100 Ug or considerably higher in individual cases, thus enabling the diagnostic differentiation between various clinical conditions and severe bacterial infection, that's sepsis. It's a terrible thing to have, and you can see less than 0.05 is healthy. Somebody said something?
No, I didn't.
All right. Was this what we are looking at?
Yeah.
Procalcitonin, best parameter for early sepsis diagnosis done on all E machines. Among the available laboratory parameters, PCT has been shown to be most useful. PCT has been demonstrated to be the best marker for differentiating patients with sepsis from those with systemic inflammatory reactions not related to infectious cause. I'm repeating it. Moreover, procalcitonin was shown to be the only laboratory parameter that made a significant contribution to the clinical diagnosis of sepsis. Information obtained from IL-6, IL-8 and CRP had no impact on the clinical diagnosis of sepsis on admission. So all these, once you have a patient with these signs and symptoms, all these tests are done. But the best is your PCT. The other cellular markers are the measurement of cell-bound receptor molecules involved with inflammation has some advantage. The volume of blood needed to quantitate the cell surface markers using whole blood flow cytometry is minimal compared to the needed to determine soluble markers. The sample size may be critical in some patients groups, such as small babies. The CD11B, CD18 receptors that mediates the irreversible adhesion and transmigration of phagocytes from the circulation to tissues is stored in the cytoplasmic granules and quickly multiplies its expression of neutrophils and monocytes upon stimulation with mediators such as TNF-A. So I think we have a nice little table here. So you got sepsis, SIRS, and MODS defining the terms. So systemic, please keep it in mind, systemic inflammatory response syndrome, SIRS, response is manifested by two or more of the following conditions: temperature greater than 38 degrees centigrade or 100.4 Fahrenheit, or less than 36.8 for Fahrenheit, heart rate above 90 beats per minute, respiration rate 20 breaths per minute, or PaCO2 is 32, is more than 32 Hg, white blood cell count more than 12,000 or less than 4,000 with more than 10% immature band forms. So that is SIRS. Now we come to sepsis, systemic response to an infection defined by two or more SIRS criteria as a result of an infection. Severe sepsis, sepsis associated with organ dysfunction, hypoperfusion, and hypotension. Septic shock, sepsis-induced hypotension despite adequate fluid resuscitation, along with presence of perfusion abnormalities. Multiple organ dysfunction syndrome, MODS, presence of altered organ dysfunction in an acutely ill patient, and that is mostly fatal. Shanti, you would like to add anything here in your experience? Shanti? We'll get it on.
Yes.
Okay, would you like to add anything on this? I'm sure you've seen a lot in your hospital.
Yes, but it is usually done in the microbiology department. IL-6 is something we don't do regularly.
Aji.
Actually, it caught on only as a research studies, and it caught on in during COVID.
Yes.
During COVID, IL-6 had a major role along with D-dimers. But after COVID, I don't think IL-6 is ever done as a routine. CRP, yes. CRP is very significantly done and gives a lot of value. So at the onset in ER, when sepsis is one of the differential diagnoses, CRP is done.
All right. So I've asked the question, can CRP also be a marker? It can when an infection that does not cause fever or the focus cannot be verified.
Yes, it's very significant.
Yeah. I quite like this test, because we get it, I think, every day, especially on kids and adults also. In these cases, the elevated serum CRP level denotes the presence of systemic inflammation and may not distinguish between infectious and non-infectious cause of symptoms. If I'm not mistaken, has this become compulsory in all pregnant women?
Yeah.
More or less? I think the doctors order it, and more everybody who comes in with a panel, CRP is added on.
Yes.
I think 95% of cases. And it's quite significant at times. Indeed, CRP is not a specific marker of infection, but is increased in a wide range of diseases characterized by the presence of systemic inflammation. Furthermore, CRP levels increase slowly and are not necessarily elevated in an early stage of infection. Although levels of IL-6 and procalcitonin and concentration of CD11B and CD18 expression increase earlier than do CRP levels, none of them is specific for infection either. You've noticed this, And I know you said IL-6 not done regularly.
No, it's not done regularly.
But I think this procalcitone is a very nice marker. It's a very
Yes,
sensitive marker.
procalcitonin and CRP are done regularly, and they give a lot of information to the clinician. And the cutoffs are also very significant. Any small raise also is followed up, and they are not that expensive also. Procalcitonin, okay, but you also have this point of care for these. How reliable they are, I am not too sure, but the ones that are done by the laboratory methodologies are very good.
Okay, all right, all right, all right. So here we go. We've got this person who is critically ill. You can see attached to monitors and got tubes running. So the first part of the table, we said infection, initiation of innate immune response. The writing is too tiny. You can read it. Then you've got SIRS, the body temperature more than 38 degrees centigrade, less than 36, too high or too low. Heart rate more than 30, we've said that before also in the table. Respiratory rate more than 20 per minute. And your partial CO2, tension in arterial blood less than 32. White blood cell more than 12,000, 10% bands. Excessive pro-inflammation response, again too tiny, you can read it with you. And then eventually this can lead to shock, and shock can go both ways, either it recovers or it can result in death. Between shock and organ dysfunction, you've got anti-inflammatory response, counteracts pro-inflammators, and so on. And shock can also lead to organ dysfunction, and that is fatal. Organ dysfunction may recover or lead to death. And if it leads to death, there is deep immunosuppression. And maybe secondary infection. So these are I think the doctors follow certain tables and certain rules. So treatment with electromagnetic beads to remove bacteria. It has worked. Shanti, know anything about it? Blood passing through and getting rid of the bacteria?
I am not familiar with this.
Treatment with electromagnetic beads to remove bacteria. So there is something there. Do we have it in India? You're not very sure, is it?
I'm not sure.
You've got blood flowing through, you've got the beads, you've got electromagnets that removes the crap, I think, and blood flows through. All right? And I think we'll come to the one more. That's it. And that's about the end of this little presentation. Anybody with questions? Rohana?
Of them from Dubai and all, do they have this electromagnetic beads? I don't know. I am not familiar with
That's the reason why I wanted this girl. She's come in and gone in, gone out. What's her name? Miss Nazneen. She told me definitely I'm joining, and she would be able to tell us a little more about it.
She messaged on the group saying that she's understaffed. It's Ramadan, so
she's messaged on the panel?
Yeah.
Okay. Okay. I wish she was on. Anybody else? Parul, you made it, or you at the airport?
No, I'm in the car.
Where are you going today?
No, I've got to Chiploon. I'm coming back.
Oh, you're coming back. Okay, I thought you would be able to make it. Yeah, because this is a very short presentation, and I thought it was very interesting, especially since we did such a lot of stuff on pregnancy, and I know that we are very careful of our ladies, especially if they show high blood pressure, proteinuria, and problems. And we've had a few where we have eventually packed them off to a bigger hospital, because we are a smaller hospital, as a 40-bedded hospital, And now we have an intensive care. We never had it previously. I think about 7-8 months now. We have a PICU. We're catering to babies, but we're also catering to adults. We're catering to kids who are 6, 8, 10, and now we have an ICU, which we never had before. So we had to pack them off to the bigger hospitals. And I know we've lost some patients. It's very sad. And young mothers of 22, 30, 32, 35. And I know we've lost some. That's sad. Anybody else? Rohana, you want to add anything? कुवैत में क्या हो रहा है भाई?
नहीं, इसका तो I have not been in touch with this. But regarding procalcitonin, there is something that they are working on. It's with this company called New Medica in US, and it's a fecal analyzer for cases. So this is using the cartridge system.
Okay. So like it's a point of care, is it? Do I unmute? Shanti, you were talking about something like that, right?
Yes, there are a lot of point of cares, but I don't know, like, yes, they have caught on in the Indian market also, but I feel that the laboratory methodologies are much more precise, but everybody cannot have big instruments in their own small setup. So these point of cares are definitely a guide, if done appropriately with whatever controls or calibrations and all, they are very useful.
Because I know I've taken this to Chennai. I've taken it up a little north. Delhi में भी बात किया है इसका, and they agreed that this was really a very, very good marker for sepsis. I think the time I spent in Roche was really, really worth it. That's where I met you, right?
Ma'am, generally, what type of infections come up in this pregnant women which leads to this sepsis? In your experience, ma'am?
Shanti, you want to answer that?
You can answer it. You can answer it from your hospital.
What do you mean, what sort of, they come to us?
Which infections they get generally, like these pregnant women, which leads to this
Starts off with a simple urinary tract infection, am I right?
Yes.
And then that's...
and it goes ahead.
Yes, and then...
Poor hygiene.
Okay.
And sometimes when they have these MTPs done elsewhere, and then they come back, then the thing is not removed, conception material is not removed completely, then they have a lot of sepsis. Of course, by that time they're not pregnant, but still they are in the obstetrics ward. So these are features that come in.
So a lot of things that contribute to something like this, right?
Yes.
As she is pregnant and after delivery also.
Yes. Poor
Products of
hygiene,
conception.
poor aseptic conditions in the hospital. Catheters are a very common feature which can cause sepsis.
And something so simple can become so acute.
Yes.
Thank you, ma'am.
And because when they have come to us, I don't deal with them much face to face, but evidently there's a problem, and it is almost like something that deteriorates so fast.
Yes.
That it's astounding that BP up down,
Because
temperature up
eventually
down.
they have multi-organ failure.
Yes.
What you call NOTS.
By the time we report it, they go to the big hospitals. It is multi-organ failure, and it's very sad to lose somebody at that age. जो already one बच्चा तो था, second बच्चा, third बच्चा में हो जाता है ये. And usually, like you said, they come from another hospital, not in Mumbai. They come from somewhere in the village or something of that sort. Anything else? Any other questions? So Shanti, you think we should go with the kidney function? And you're going to prepare it?
Yeah, I will.
Okay.
But I need time, not in February, maybe March.
No, you can do it in March or so. Because even, what's her name? Nazdeen has asked for time. She's asked for time. Yeah, I want some interaction from you guys, you know. I would like that. I would like that. Rohina, you're going to do something? Since you are in the field. Hello? Rohina still not over her COVID. Alright, then I think we'll end. And
Okay.
we'll come back again.
Yeah.
Maybe sometime in March. You
Yes.
have certain ideas, guys. Tell us what you have in mind. Okay? And we'll take it from there. See you.
Yes, ma'am.
And thank you for all your support
Thank you.
and love. And like I said, I always thank my crew at Mowdawala Hospital, including Nikhatya, who's with me every afternoon, and Munira and all of them. You know, they are very, very helpful. Thank you.